So if I can have the first slide, please. So down below you can see my different disclosures. One, of course, is that I'm President-elect of the European Atherosclerosis Society, and therefore I will tell just briefly about our society. So what it does, you see up on front, is we have different publications, guidelines together with European Society of Cardiology. We write a lot of consensus papers, have the journal Atherosclerosis, and then there's also something called Clinician's Handbook and Young Fellows publications. And then we do have a lot of educational activities, and I hope people in Vietnam could be interested in that. For example, our Congress yearly, next one in Glasgow. We also have something called Rare Lipid Disorder courses and many webinars. Then there's something called the ES Academy, where as a country member everybody can access. There's Young Fellows program of ES, certificate in lipidology, both for clinicians and for nurses and other healthcare professionals. And then we have lots of communities and collaborations worldwide. There's the EAS FH studies collaboration, I'll mention that shortly. There's the Lipid Clinic Network. I know both of these, Vietnam is involved. There's the National Atherosclerosis Societies, and then we have something called the European Liver Pudding Club. But there's also other scientific organizations, patient organizations, public health policies, and global regional meetings that we are part of. Here just illustrated that our society is 60 years old, and we have had 92 different congresses, yearly one, so it's very old. We put out this prize called a Nordestgaard prize, 79 of those. We have 99 countries where EAS members live, so individual members from many, many different countries. We have about 3,000 individual members that are the ones that can elect people for office. And then down below you can see there's National Atherosclerosis Societies associated with EAS, there are 39 at present. And at our congresses, the last one this year, we had about a bit more than 2,000 participants, and with online 2,500. We have 5,000 followers on our website and 22 current industry supporters that we've had for a long time. And then just here also, we have these countries covered by the Lipid Clinic Network. There's 50 by now, and about 500 lipid clinics, but it's still expanding, and I think there's a new initiative we like very much. There's 13 clinics contributed to something called Lipid Registry in Africa, so we try to, if we can promote more statistics in Africa. And then finally, there's all these patient cases in the FHSE registry. So now I'll come to this topic here. Familial hypercholesterolemia, I think, is the most important to talk about when you look at common causes of atherosclerosis in children. Here's from Brown and Goldstein, a publication they had in 1984, explaining how it works from their point of view. They got the Nobel Prize in 1985 for discoveries like that. On the y-axis, you can see the number of functional LDL receptors, and in adult animals and newborns, there's very high levels. But then when you live in countries where you eat a lot of fat, it comes down to about 60%, and that means that the cholesterol levels become a normal distribution, quite high, with a mean level of 3 millimoles per liter. If you're heterozygous FH, your number of LDL receptors are half of that, and then you get to even higher LDL. And then if you're homozygous FH, you get to very high LDL levels, and for many of those, they have absolutely no LDL receptors. So here's just very simple explaining that LDL, of course, is mutations in 3 different genes: LDL receptor ApoB, PCSK9. LDL receptor here on the liver surface, ApoB, interacts with the LDL receptor, and PCSK9 are important for recirculation of LDL receptors. Then you have a liver with 50% functional LDL receptors if it's heterozygous, leading to much higher LDL cholesterol levels, early atherosclerosis, coronary heart disease, and then myocardial infarction or angina pectoris. I think for now, many people think LDL receptor being the most important, then ApoB and PCSK9 mutations quite rare. So here's simple explained that familial hypercholesterolemia is a dominant inherited disease killing most people. Cardiovascular disease in FH is actually 100% preventable using statins. At least we talk for the heterozygous. So that's why it's so important to find them, even the children. On the one side, I think there's some numbers saying 1 in 250 has heterozygous F8 on the one side over here. That's in the general population. But if you look at the two different alleles, and then you can count that homozygous F8 will be roughly 1 in 250,000. And if I translate that to Vietnam, meaning there will be 400,000 children or adults with familial hypercholesterolemia heterozygous, and about 400 with homozygous F8. This is important, of course, because trying to illustrate here as a function of age of people, what is the cumulative LDL cholesterol burden, meaning how much LDL has a person's arteries been exposed to over the lifetime. For a normal person living like in my country, Denmark, there'll be this curve, the green one, and it will hit about 160 millimoles. It's not millimole per liter, but millimoles when you have risk of coronary heart disease. If you're unlucky to get heterozygous F8, you already get the risk at 35 years, and if you're homozygous, already in childhood. So many of these children will simply have coronary heart disease or die before age 20 if not diagnosed. And untreated heterozygous will be about after age 35, and they will have diseases, maybe men and women 55 or 60 or older. If you do give a statin early on here in childhood already, which is recommended in many guidelines, you can almost change the trajectory to that of normal people. If you wait till people become adults, it's very hard to get like normal people. So here's a meta-analysis we conducted with all what was available in the world at that stage, and what we found, taking all available data, I think about 6 million people worldwide was in the studies, that in the general population, 1 in 313 had F8s. If we looked at those with ischemic heart disease, it was 1 in 31. The one with premature ischemic heart disease, it was 1 in 15. And if we looked at people that were in lipid clinic with severe hypercholesterolemia, 1 in 14 had familial hypercholesterolemia. So among those, you'll find lots of children. Here's a map we published in this JACC paper, and you can see these are the few countries in the world where somebody actually tried to estimate the incidence of familial hypercholesterolemia. And when we looked at that stage, Vietnam did not have data, but maybe somebody has published in the meantime. Please tell me if that is the case. I think this is very persuasive for finding the children with F8 early on. This is a publication by Admit Kira in JACC in 2016. And what they showed here, based on a number of different cohorts in the US, is that, for example, when you look here, down here, at the ones with low LDL, less than 130 milligram per deciliter, these are the ones without mutations, but these are the ones with F8 mutation, meaning that they have had a lifelong exposure to high LDL cholesterol. And here, even at the very low levels, if you have an F8 mutation, you have twice the risk of coronary heart disease. But if you look at the very high levels here, if you have LDL more than 220, the ones without mutations, they have 7.7-fold. But the one with beta mutation at the same LDL level, they have 26-fold increased risk. So I think that's very persuasive to find the one with familial hypercholesterolemia. Here's my thinking of the evolution of F8's understanding genetically. When I was a very young doctor, essentially most people would just look at clinical F8s, but then came Brown and Goldstein realization of the LDL receptor, and it took some years before clinicians would say, well, we need to understand LDL receptor in our patients. This is also F8. And then came research on the mutations of ApoB, and that also took some years before people realized this was also familial hypercholesterolemia. Later came LDL, RAP, and then PCSK9 mutations, and all of them take some time before they get into clinical practice or people's thinking. I think the latest one is lipoprotein little a. Many people still say that, oh, lipoprotein little a, that's not F8, but it's actually coming there. More and more realize this is also part of clinical F8. So some argument that we hear is that these three LDL receptor, ApoB and PCSK9, they are dominant, and therefore this is the real F8, some people say. But then LDL-RP, that's actually a recessive disease. And I would just say that the LDL is just a multi-allele genetic cause of familial hypercholesterolemia. So I think, why do something about it? Why is it important? These are data from the Dutch that are world masters in finding F8s and treating them. Here were missing in British Medical Journal 2008, that the green line is patients with F8 in the Netherlands treated with statins, and here's how many were event-free of having coronary heart disease, and they compared them with some that did not get a statin, and you can see after just 10 years there was only 40% that did not have a coronary heart disease event. And then later Albert Wigman published this one here for children. So what he did show here was that cumulative event-free survival, meaning that you did not have a coronary heart disease. These were the children that Albert Wigman in Amsterdam had followed. He just gave them statins early on, and not a single one of them had had coronary heart disease at age 30. And when he compared it to the parents at that age, already 10% have had a coronary heart disease event. So I think F8 registries are very, very important for finding these, particularly the children, because you have the families. So please use them to secure appropriate LDL cholesterol lowering. And here's in what's called the European Atherosclerosis Society F8 registry, and I know Vietnam is part of it. And you can see here, there's many, many countries that have contributed data to this registry, and I think that's one way forward to try to find them. Here's the latest publication from that registry, 2024 this year in The Lancet, where what you see here is on the x-axis age and on the y-axis LDL cholesterol in children all over the world from age 0 to age 18. And you can see if they're not on lipid-lowering therapy like these, it's really an average 5 millimoles per liter, and that's corresponding to about, how much is that, 5 times, Peter, how much is that in milligram per liter? I can, 200, about 200, yeah. So there's all these children all over the world. In Denmark, we are behind the Netherlands and Norway, but we are starting now to try to make a registry. So what we've done is that it started in 2022. I was part of having politicians funded in Denmark. And what we did here, we have some data sources and then data processing, and we have quality indicators, and then we have quality assessment. And it's called the Danish F8 registry. So we have manual registration in the various lipid clinics. All of them in Denmark are attached to it. And then we hook it up to the Danish National Patient Registry, to the Danish Civil Registration System, to the Danish Laboratory Information System, and finally to the Danish National Prescription Registry. So we know all what happens to these F8 patients. And quality is that we have some quality indicators from the diagnosis of F8 and their relatives. We have some for dietary counseling and lipid treatments. We have something lipid achievement and treatment goals, and finally something about the prognosis of F8. And this is there's a report every year that comes out that is sent to the different hospitals to improve treatment in Denmark. And so this yearly quality assessment for F8 in Denmark, it's a taxpayer-funded administrative team that prepares an annual report, which is sent to the steering committee, and I'm one of them. We see it, and then when we accept it, the report is sent to all Danish hospitals, and any poor quality, the hospital try to improve how to find F8. And then finally it's sent to journalists. For example, in my region there was a bad thing or something, and the journalist called me and said, how come that you don't find enough F8 in your area? And I have to explain what they could do to find more. So we have this plan here from 2020 to 2030, how we should find all F8s. And we started here with about 8,000 is how many we should think, and we believe that we will be able to find them by 2030 something. Some of the genetic or quality control we have is that everybody should have a genetic test, and we decided on a standard of more than 70%, and actually in 2023 already 84% had genetic test, and we all decided everybody should have Lp(a), 84% had that, and then there's 10 other quality indicators. So just a little bit back to F8, these are some new thing. I think the Lipid Clinic Network that I hope many in Vietnam will be part of, that we are part of a process to try to standardize lipid clinics, how they work worldwide, there's a process, and then implemented in each country, country specific, and then finally get some ways to do it better worldwide. Here's new and updated things from the ES publications. We try to, if we can look at lipid treatment simplified, there's consensus on different topics and young fellows reviews. Education activities, we have these certificates for nurses and healthcare professionals that will coming forward, your lipid clinic today, and of course the Congress in 2025. And then communications, lipid clinic network, we spend a lot of time on that. There's the Region Alliances Initiative, and then this African Libra thing that is going on. And so the Regional Alliance Initiative, it's trying to collaborate with countries outside Europe, bring together national societies and regions for workshops, 2 to 4 year cycle with different regions in Latin America, Asia Pacific, which is here, Africa and India, and workshops in the regional, together with these different countries. So, and my last slide is just to say that we have this congress in Glasgow, so anybody that's interested in coming, I'm sure it'll be very good. I'm not the only one doing the program. There's a whole program committee with all the newest research, so I'd love to see some of you there. Thank you so much for your attention.
Ja,